Hello and welcome to today's Population Health Alliance webinar. These are monthly webinars and it's summer already, which is unbelievable, where we offer real-world lessons on the provider-based dimensions of being accountable for the quality, cost, and patient experience of the populations we have the privilege to serve. My name is Jan Sidorov. I'm the CEO of the Pennsylvania Clinical Network of the Pennsylvania Medical Society, but more importantly, I serve on the board of directors for the Population Health Alliance. The Population Health Alliance is a member-driven organization that aggregates and aligns stakeholders in the continuum of care toward the goal of improving the health of population. If you become a member, Population Health Alliance members gain the opportunity for mutual education, like right now, support advancing their organization's visibility. We can influence industry trends, maximize effective communications to key stakeholders, and respond to industry issues with the strength of a broad-based coalition. Join us. We in the population health industry will be stronger and better advocate for our patients with you than when we are alone. Speaking of which, you can also become an individual member. We're happy to announce that we still have, in addition to organizational memberships, the new individual membership category. To find out more, just check the membership tab on www.populationhealthalliance.org and look for the membership tab. One other thing I wanted to point out, and that is the Population Health Alliance's Innovation Summit and Capital Caucus is being held this October 29th, just a few months away. And the good news is that early bird registration is open. This summit is PHA's premier annual event. It's held in Washington, D.C., and provides a great opportunity for direct engagement with the nation's foremost population health leaders, as well as regulators and politicians with a stake in this field. Convening along the intersection of financial security and population health management, this year's lineup of speakers provides a unique opportunity to learn and develop your own plan to tackle this important dimension of social determinants of health. This event is open to members as well as non-members, and all the information can also be found at the populationhealthalliance.org website. Go to the AICNY tab. And now for our speaker. Dr. Sanjay Seth is the Chief Medical Informatics Officer of HealthEC, where he develops approaches to develop providers and organizations participating in healthcare programs, physician engagement strategies, care coordination, population risk management, ACO strategies, and payer-provider contract negotiations, all of critical importance to us in the provider side of population health. Dr. Seth has supported 2 physician groups in the formation of an accountable care organization under the MSSP initiative, creating collaborative care coordination agreements, and introducing technology and processes to manage ACO operations. He also established a payer-supported virtual patient-centered medical home program for over 15,000 lives. Prior to joining HealthEC, he was part of a turnaround team for the Interfaith Medical Center in Newark Beth Israel Hospital at Orange and East Orange General Hospital, leading the implementation of complex hospital and physician, clinical, financial, contractual, and compensation relationships. Dr. Seth has led numerous physician groups in their formation or restructuring efforts, including the modification of billing systems, implementation of electronic health records, and the development of partnership agreements. And on a personal note, I've seen Dr. Seth in action, and I've never seen him not be the smartest person in the room. Just a quick word about today's presentation. Copies of the slides will be made available upon request, and the webinar will be posted online later for repeat viewing. Sanjay, thank you so much for being the smartest person in this virtual room and for leading today's webinar. The floor is yours.
Thank you, Jan, and you've laid such high expectations of what I'm going to say that I hope I can live up to it. And thank you all for joining, and I hope that we can contribute some meaningful information in where to begin and where to proceed or how to proceed with value-based contracts. And I know it's not an easy task that we are all facing. What I want to focus on today is how these negotiations or performance must be data-driven and not shooting off the hip or off the cuff. So let's start with this process. Is the first thing is that I hope everybody understands the rapid rise in both the value-based care programs or contracts being offered by the payers, including CMS, and the rise of integrated networks. As Jon indicated, that these networks are beginning to become more virtual than physical. That means they're operating under multiple tax IDs rather than under a single umbrella. But none of this transition or transformation cannot begin without data. So the idea is to gather as much data as possible before you enter into any transformation process with a payer. And Jon and I have both seen this work its miracle when we were helping a group of, I think, nearly 200 pediatricians and OBGYNs to begin a process of negotiations or conversations with the payers. Is how we were able to use the data that was within the EMR and practice management systems of these practices, get us to a point where the payer recognized the value of dealing with somebody like that organization. However, you need to bring the data into a solution or a platform that helps you strategize and optimize care management, because we don't have unlimited resources. And then using the data and analytics to drive compliance and performance at the individual provider and practice level. And lastly, I will show you some of the successful programs that we have been a partner to, and some of the lessons we've learned from that. We all talk about triple aim, but we forget all the stakeholders involved in the triple aim. It's not just the patients for whom lower cost and outcomes, and now moving towards more personalized care is a need or a demand, but more importantly, that the experience is better. So sometimes we forget what is it that the patient experiences that drives engagement and success. Patients may or may not recognize the value of one medication over another, but they do recognize the value or the benefit when they are prescribed one set of medications versus another that makes them feel better. Feel better and getting better are not the same. So please be aware that patients need to have a better experience, not just better outcomes. Providers, with the conversations today about burnout and the increasing workload on the providers, the systems and administrative or technology wise must work to improve efficiencies, reduce workload by integrated into workflow, and the providers are going to be happier if the patients are happier. So the providers need to focus on what is making the patient feel better. Again, I'm using the word feel, not get. And then they need to realize shared savings. Without that added incentive, they tend to be disengaged. So the providers, then the payers, of course, with the pressures on our system for healthcare costs rising, there is no question that the payers who administer health plans or self-insured populations need to find a way not to go back and ask for increased premiums, which can only work if the providers cooperate. The suppliers that support the entire health system, and here I'm mainly talking about the home health, the DME guys, the health home folks, the community health providers, their supporting organizations within the community. All of them need to play a critical part, because the more care we keep out of expensive locations, the better off we're all going to be. And then finally, the entire society or the entire population benefits from having overall reduce spending and better health, because absenteeism and productivity and efficiency at the workplace is impacted. So there are many stakeholders, and we have to be aware that the value-based care does impact all. One of the things that we're trying to show is what is happening with the practice ownership, and we can see this intersection of lines that I was tending to replace year 1, year 2, year 3 with the actual calendar years, but it's anybody's guess when this actually has, either it has already occurred or it is occurring. But we do know it's occurring, that the physician-owned practices are on the decline because of the stresses they're facing as individuals, whereas hospitals trying to protect their territory or turf are trying to assimilate more practices. But how the organizations or how the providers are organizing themselves could be any one of these following programs, and we have never given up in healthcare of the 3-letter alphabet, but it's beginning to become 4, as some of us can see. But anybody and everybody in this circle around the patient becomes a part of an organization, and I think they're truly being described as integrated delivery networks. Another slide to show you that how the growth in the number of ACOs and contracts, as well as the number of lives being covered by under these value-based agreements. And again, this is maybe a year old. Haven't seen something come out more recently, but I can't imagine that the climb has flattened out or is on the decline. In fact, I think it's going the other way around. Any value-based transformation other than behavioral transformation begins with data. So what do we need? How do we need to think about it? We need to think about it by talking about how are we going to create a subset of our entire population that we are going to try and manage more acutely or better or in duration of time. So you need to determine what population are you going to address. And as physicians or as clinicians, we try to focus predominantly on disease-based cohorts, but there are many other ways to group patients and create models. Once you create the model, you can then determine who needs to be in that sphere of patient care, and those are your partners that you would bring into the picture. Once you do that, they also become your data sources. So you need to make sure that you have the right solution to bring in all those data elements, because without that, if you are unable to aggregate all the data from all the partners in the program, you're not getting a full view of the patient. And without getting that full view of the patient, how are you going to create the analytics or look at the data so you can assess what the overall health of the population is, identify those that are either high risk, high cost, or what we are beginning to also see is that most payers are starting these programs with just simple quality metrics. So paying for quality is certainly step 1 in most places. So that brings in the care gaps. If you don't know how your population is doing or your patient panel is doing on a real-time basis, you're never going to be able to catch up. So relying on the payer to give you a report at the end of a quarter or a month to tell you that this is how far along you are, and I am very surprised if somebody tells me that the payer is sending them reports every month. It is becoming a feature right now, but it's still really rare. Once you have that cost, quality, risk, gaps in care, then you can make informed decisions about when to bring a patient in and what to modify in the patient's care plan so that the outcomes are achieved. And in every value-based contract, quality is a factor. And you could drop, even if you're doing a shared savings, you could drop significant dollars if you haven't met your quality benchmarks. Data. So once we have the data, having raw information is useless unless it's transformed into something that is meaningful at the provider or the user level. That takes a process. So taking data and transforming it so that it is presentable, it is analyzable, and then taking that same transformed, cleaned, normalized data and creating the analytics that is going to help with the transformation is step 2, which is what should drive your care transformation by patient or overall, and that will automatically bring in the dollars. Remember, the best business for medicine is good medicine. So making sure you take care of your patients well, the dollars will flow automatically, whether you're doing it under the current model for fee-for-service or you're doing it under value-based. Of course, the returns are enhanced in the value-based if the care is even better than it is today. And of course, all of this means that the entire practice needs to transform, which means the front desk, the intake process, the in-rooming process, the discharge process from within the practice, all of them need to transform how they view a patient and use data and benchmark to drive change. Question is, what solution is the right solution for you? And that is, you do not want to be moving from platform to platform, from portal to portal. So trying to find a solution that brings all of this together is the ideal objective. Easier said than done. But if, depending on the programs you are going to take on for the care of your patients, look for those solutions in the population health management platform. If you're worried only about your shared savings and Medicare shared savings program, you don't need to worry about all features that may be needed if you are also looking to do social determinants of health. If you are also looking to integrate behavioral health into your practice and assessments. Not a critical requirement for shared savings, but if you start partitioning and looking at different systems for different populations, it's going to make management even harder. So depending on what your program is and what services you're looking to add to your practice, that would be the choice of the platform that you need to make. This one shows that if you have a 360-degree view of the patient, then the data made available to you from this process can cover any one of these situations. You could see which managed care organization or network you're performing best and use that as a benchmark for your internal benchmark to improve care, regardless of which plan or payer the patient belongs to. One of the things that we are all failing at significantly is monitoring medication. Whether you're monitoring it at the cost level or you're monitoring at patient adherence problems, and with an acute focus today on substance abuse and opioids. The reason these have become issues is because we haven't paid close enough attention to medication monitoring in the past. The focus on hospitals and clinically integrated and integrated delivery networks is because we need to become an ecosystem, a community that gets together to provide care for the patient. So you can't simply have scorecards for the hospitals, you can't have scorecards for the providers, and you can't have a different scorecard for the MCOs. What you need to do is bring all that information into one place so that the health plans you can have a meaningful conversation with the health plan about the value of the data aggregation you're doing. Again, on the left-hand side of the slide is all the typical data sources and what that brings into what elements of data that come into a data warehouse where you're trying to create a master patient index so that you're not duplicating records. It is based on that you then start to stratify patients. And I've used a very old-fashioned term here of hotspotting, which some users tend to shy away from, but it is true. You need to identify where you need to look for problems. And you can only do that by figuring out the stakeholders and where the issues lie. So you could start with a program that says, I have patients with tremendously high use of the emergency room for non-emergent reasons. And that could be a starting point for everything that you do within your practice. Eventually, it will involve all of these elements. And so be aware that without this data, you're not starting anywhere. I'm going to skip this because this truly talks about creating a personalized community record for the provider, for the patient, and for the provider. And this is where patient satisfaction could be the greatest. But this is an undertaking that I think is step 2 or phase 2 of any value-based contract that we are seeing today. It's becoming more of an issue for the government and the quasi-governmental agencies and the health plans to bring in community stakeholders into the patient's record. But once we have decided that these patients need attention, the question is, how do we create or integrate into the workflow of these care coordinators, who could be a nurse or a medical assistant or a physician extender within the practice or within the hospital? How do we integrate into their workflow and keep them abreast of their own requirements and performances? But you can't do this without data. So how many new patients came into my program today? Or how many are in chronic care, and which patients I have not seen a response from, so they're unreachable? And what are we doing with preventive care? What are we doing with annual wellness? And who ended up in the hospital, or who got discharged from the ER, as well as where is my focus on high risk? And creating reminders for ourselves so that we don't have to rely on memory to call Mrs. Jones on Thursday. The system should be able to tell you, hey, you need to call Mrs. Jones on Thursday. You set yourself up as a reminder. These simple one view dashboards trigger all the memories that typically we feel that as providers we already have. It just needs to be refreshed, and that's what the system should be able to do. That's what the data should support your performance. Again, we could talk about monitoring gaps or tracking patients. Either way, the system needs to be enabled. It can't be only on desktops. It has to be mobile enabled, because all of us are in different locations at different points of the day, still needing those reminders. So again, selection of the platform is important, but the data is even more important, to know that for this particular patient, Bob Bell, that I still haven't done a clinical screening for clinical depression and a follow-up. And in this day and age, incorporating all of that behavioral health into the practice is so important. And some of us fail to recognize these features, and it causes issues with ER use and admissions and non-compliance with medication. So everything needs to be tracked, and we need to be reminded on a regular basis. Here is an approach to care coordination. Care coordination is not simple. In its delivery, it is. In its initiation, it is not. So how do you use data to decide what approach to care coordination you're going to take? Whether you're doing it on risk, or you're doing it on high or rising cost patients, you're doing it on diagnosis or cost per patient, or you're doing it on ER use, non-emergent use, somewhere this is going to have to be analyzed through data to say, where is my biggest problem? And then the second question, which is even more important, what are the resources I require to assess or to attack or address this issue for the maximum return? Again, without data, that's not going to be an issue. If we were looking at a high inpatient utilization as a total cost of care as a problem, I need to look at those patients that have been causing admissions. I need to look at those patients that have been going to the ER, because we all know 30% of all ER visits end up in the hospital. You could see that the patients are those that are frequently admitted or admitted for low acuity. Where were the readmissions occurring, at which facilities for which diagnosis? And where have we lapsed in the focus on chronic care or wellness that led us to this point for each of these patients? The next one on the HCC actually should be the last point, which is how can we change our benchmark? Because every premium dollar, both to the payer and from the payer, is risk adjusted on HCC. And remember, HCC is reset at the in January of every year. So sometime in the middle of the year, you need to start reviewing what diagnosis you included for this patient in a claim last year needs to get put into a claim this year that you haven't done so far. Assessments only come into play once you've decided an approach to care coordination, and assessment should complement any strategy that you pick for care coordination. And then the results from the assessments should give you data to take action. It's not just having the assessment done, but it is what are you going to do with that assessment next. Without patient and provider engagement, everything becomes a struggle. Again, data is the easiest way to engage both provider and patient. Without sending the patient or notifying the provider with data, the attention is shorter than we would all imagine it to be. And I don't want to call it ADHD, but none of us have the time to read statements and paragraphs. We're looking for a snippet of information, no more than the 200 characters in a Twitter feed that is gaining so much attention these days. But certainly using data to communicate is much quicker and faster at the appropriate level. Patients may not recognize data. They may only recognize statements. So be careful about simply transmitting raw data to anybody. Quality. We know this is a place to start. And if we go through this, you could see how many quality metrics can be brought into the picture by any plan. It is very cumbersome. And advice would be to stay with claims-based measures to begin with before you get into hybrid measures. But of course, the whole program of MIPS is complicating that as we speak. So we know that you have to pay attention to it. Again, finding a way to display data or visualize data is really important. So in the HealthEC tool, what we try to do is give you in one page everything you need to know about your own practice or provider, where I'm looking at the provider's performance on the left-hand side by all the key performance indicators or metrics in a value-based agreement that I need to be watching. and this provider's performance along those lines. In this particular example or slide, we have selected admissions per 1,000, and that shows you the monthly trend for 2 years. And so we would want to watch that if somebody is having seasonal variations, and you can see that there's some evidence of seasonal change in this particular provider's practice, but otherwise maybe not as useful. But at the bottom half of that page tells you the individual provider in the practice. If it was a practice tab, you would see the practice's performance, and to the right, you will see the provider's performance. And here you're benchmarking the key performance metrics against the national benchmarks for a shared savings program, whereas at the provider level, you're benchmarking them against their peers. And to be able to see those 67 patients in the panel would be, should, and is a simple click. If we click on 67, it'll tell you all 67 patients that belong to this patient, this provider, and which ones of them have had admissions and how many, and what the total cost has been, as well as using algorithms to predict the likelihood of hospitalization over the next 6 months. And that is something that you could use to then manage this patient just that little better, to make sure that your overall rate for admissions per 1,000 matches your peer group. Same provider, same service. I'm looking at a period in time that says, okay, which were my high priority patient lists, and what I determined to make this list a high priority. Was it diagnosis? Was it the chronic condition hierarchical group, or was it something else? This data is now presented to the provider on the next screen, saying your admissions were a problem, here are the patients, and these are your high priority patients that you should be addressing. Using this information, and information in addition to what I've just displayed, I can give you some examples. In New Jersey, we have a group of show quality partners. It is a hospital with an employed physician group plus a community-based provider panel of over 260 providers. And they have consistently performed to make sure that they continue to entice them to continue to add more value-based programs. And we implemented this solution in the fall of 2015 with them, because they saw this trend between 14 and 15. And then 16 became, they thought, a banner year. I haven't put that in here. 17, the number went up to 2.9 million, and 18, which we haven't received the MSSP results for yet, but it's looking like another 15% increase over 2016. It also enabled them to take and move into a risk contract in January. And so we have data has enabled them to be confident enough to move along. Here is another one, the Princeton Physicians Organization, a much larger practice of a group of providers. They're independent, they're over 600, 500,000 patients. We have brought together about 75% of all their providers' data into a data warehouse, and they have now, this 2018 ended up with a $4.5 million in shared savings from one of their contracts, where they have significantly demonstrated to the payer that they are able to make changes. And the payer in this instance was also willing to increase their fee schedule in addition to giving them a value-based contract. So having both is a possibility. It's not out of the realm. This particular example is a shared savings program in Florida that has groups in South Carolina, Georgia, California, Pennsylvania, and they are seeing consistent consistent results across all their programs in every state, and the ability that they have now enabled using data has become sort of a true case study of how the operations of a single entity can be scaled to accommodate multiple locations and multiple providers. This particular study was is fairly unique because it takes care of intellectually developmentally disabled adults, and having had this level of success with this population, using data to manage the patients in this really hard to coordinate care for, because these patients live in group homes and with parents who do take care of them, and out in the community sometimes by themselves. We really needed to think outside the box, and the technology enabled them to do that, including the extensive use of telemedicine. Even before reimbursement for telemedicine was made available, has been a significant achievement. And you can see this teletriage kiosks that we put into every group home, what that did to the ER visits. I'm going to stop here and leave some time for questions and answers. And Jan and Anu, you guys, I'm assuming you guys are going to help me with that. Happy to answer.
Absolutely, Sanjay. People should realize that there is a dialog box attached to the application, so please make use of that to type in questions. I and Allison will moderate the questions. We do have one question, Sanjay, and it's from me. I think I already know the answer to this, but it is still a big issue among providers, especially primary care providers, especially among physicians, and that is screening questions. For example, for like depression, are very, very useful tools in care management to help not only address mental health issues, but to also inform risk stratification, because as we know, the presence of depression makes the I guess the trend for rising risk to be steeper than it otherwise would be if a person is battling that also. The providers, however, like me, were enculturated over many, many years that when we are confronted with a single patient with a single diagnosis of depression, that could rarely include the risk of self-harm, that is something that rises to the top in terms of being needed to be addressed, and it goes from being a population health metric to being a very, very important clinical an important clinical diagnosis that needs to be addressed one-on-one by the provider. Given that, you know, up to 10% of a population could trigger that screening portion, what's the risk to an organization that all of a sudden my personal clinical inbox and my clinic appointment schedule is going to be overrun by patients who said yes to screening measures like, are you depressed, or other things? There's a, you know, as you know, there's a line that separates the two worlds, but sometimes one can bleed over into the other. And what do you do when doctors say, yeah, but you're asking about depression, but now it becomes my problem?
Well, I think that in today's day, you know, depression could transfer categorization of a patient from being a legitimate user of opioids to being a potential abuser. So that's one real fear that that brings about. But on the other hand, not addressing the issue or not clarifying whether that single question, that they were depressed nearly every day, it doesn't go any further to suicidal ideation or them taking some risk. On a clinical side is obvious, but on the financial side, those are the patients that end up in the ER, that end up in hospitals for unrelated issues. And that brings about a whole change in utilization and cost. So the implications of not addressing that overcrowded inbox, and trust me, that I know at the practice level that becomes sort of a burden, but it also then determines what kind of resources you should have in the office to help nip some of those things in the bud. That is the real world, both experience that we have seen on the clinical side as well as on, in a value-based contract. And it should lead to the next discussion with the payer should include this conversation that, hey, 30% of my panel is also depressed. What resources do you as a health plan offer so I can take advantage of, or I need a better risk stratification program and an adjustment on my premium or in my shared savings because of the significantly high depression population. Same data used multiple ways. Did I answer your question, Jon?
Yes, it does. I do have one question from an audience member, and that is not necessarily all OB-GYN physicians are available or practice in settings that are primary care. They look and act and feel more like specialists. I'm paraphrasing here. The question we have for you is, in these settings where you've seen OB-GYN be primary care, is it all OB-GYNs who participate as primary care physicians, and is it as simple as you're an OB-GYN, so therefore you are primary care?
I think we're seeing both. In the shared savings program, the OB-GYN is focused on obviously the GYN side, and they're often treated as specialists. But urogynecology and oncology gynecology, we are beginning to see as high cost drivers of the in the Medicare or MA population. However, in dealing with the Medicaid and the commercial ACOs, very hard to exclude OB-GYNs from a primary care status, because attribution at the, from the newborn to the pediatric age, the first year, is significantly impacted by having OB-GYNs as primary care. Medicaid contracts somehow are very hard to manage without having OB-GYNs. On the other hand, OB-GYNs were the first providers in our system to accept bundling, to take risk, because they got paid a flat fee whether they did a C-section or they didn't, and it included 9 prenatal visits and 1 postnatal visit, sometimes with ultrasound, sometimes without. So they've truly understood the concept of bundling and risk, and that makes them a valuable addition to any organization because we can learn from that. But that's the 2 ways we've looked at OB-GYNs.
Great. I believe, Allison, you have a question?
I do. This is from an audience member. please talk about your experience in dealing with social determinants of health, including assessment and interventions, including data necessary for social determinants of health?
We've got, in Maryland, we have actually the county health department that initiated this project a couple of years ago of what to do with social determinants. So what we did with that was we got the claim files and the beneficiary enrollment files from all the governmental agencies and Medicaid. We started there. We now knew each patient or each resident of that county who they had encountered, with whom they had an encounter, a hospital, a physician, the crisis center, the emergency housing. We knew all of that. So we attributed these residents, and I wouldn't call them patients or beneficiaries yet, but we attributed these residents to each of these provider groups or agencies. We created the social determinants assessment, and we used Prepare for that, and we digitized that process and then made it a responsibility for any provider or any agency that had interactions with that patient to try and complete that form. Because it was cloud-based, one agency could, may have had the time to answer 4 questions, and the other agency or the provider had another opportunity. But since it was cloud-based in real time, the assessments were completed. The assessments automatically triggered referrals. So if a patient had food insecurity, maybe if they were, of the childbearing age and they were referred to WIC, or if they were a child, otherwise they were referred to a food pantry, they were referred to emergency soup kitchens, or even Meals on Wheels. And the system then tracked, because we created a coordinator within each agency. We alerted that coordinator within that agency that you have a new patient referral, that something needs to be done. They did this for 3,500 patients over a year, and I think they generated 13,000 referrals and tracked completion of all of them. I think there was a 50% completion rate. We then looked at these patients and evaluated their utilization of emergency room and hospitals, and found that there was a 17% reduction in use of ER and hospitalization, and that was about a 21% reduction in cost for these patients as a total cost of care. So they are now looking, in fact, we had a session with the state, and Jan, you and I know we've presented this to the state of Pennsylvania as well, where I think it's now we're trying to push this responsibility out to the state at the state level, because all the governmental and quasi-governmental agencies also need to be involved in the process. But we have seen real impact from gap closures and referral closures for social determinants. And the system is designed that the assessments will automatically generate these workflows.
Great, thank you so much. And we have one more audience question. What is the best way to pick a health management platform? Where do we find this information?
One of the easiest ways, and I know obviously we are participating, there's an organization called CLAS, KLAS, and CLAS Research, I think is the official name. They have been doing evaluations of population health tools. I think they have this 2018, 17, 18, 19, they have done, I think, 26 different organizations. And they're not evaluating it from a technology perspective. They're evaluating it from its usability and efficacy perspective by talking to clients of that entity. So that's a great place. They give you a comparative report between all the platforms, for free. It doesn't cost anything. You simply need to register with them on the site. And happy to say that we are at the top of that list as a best in class for 2019. And I'm hoping that we continue to keep our position.
Great. And we have another one. How do you help physicians and care teams track and deal with what is happening to patients with social determinants of health, which have been referred?
As I said, the platform that we have created, the module for social determinants, makes sure that somebody on the receiving end of that referral, there is a point person appointed there that is responsible for looking at everything that comes in. The system tracks that they have actually logged in and looked at it, and also tracks that if they went to a different site to, say, maybe initiate an interaction with the patient or the provider, we keep a track of that, and all that documentation is presented back to the provider. So in either as alerts or on the portal, they can do both. So if we get a notification that Meals on Wheels actually delivered food to the to this particular patient who lives on the 3rd floor and uses a walker and hasn't been able to get food, then the provider is also notified that the event actually occurred. So they don't have to now make a phone call and say, did you see Mrs. Jones? Did you do anything? All of that time wasting tracking is now eliminated. So that's how we keep a track of that. Even if it's emergency housing in DC and in Maryland, the emergency housing unit has a project coordinator for this and keeps a track of all the new referrals coming in. And we use the same process even for specialty referrals. So if you referred a patient to a nephrologist or endocrinologist that is a part of the network or can be brought into the network, we do the same thing. So it's not just for social determinants. You could use this tracking mechanism and completion for subspecialty or specialty care as well.
Great, Sanjay. There were a lot of questions, I think, speaking to the value of today's webinar. Thank you so much for providing an outstanding discussion on this part of population health. Data is truly everything. Our next Provider Series webinar will be held on August 7th, so please mark your calendar. We have a great speaker, a single pediatrician in private practice who continues to support and benefit from, along with her patients, a PCMH, patient-centered medical home approach to population health. By the way, if there's anyone listening today with an interest in sharing their success as providers in successfully deploying population health, please contact us at the Population Health Alliance. We're not hard to get a hold of. Last but not least, don't forget about membership and joining either at an individual or a company level. And keep the October 29th day open. We'll see you in Washington, D.C. for what will be a great day-long conference. This ends today's webinar, and on behalf of the Population Health Alliance, I thank you for today's attendance, and we look forward to seeing you in a month's time. Thank you so much, everybody. Have a good afternoon.
Thanks.